You're listening to Online Pet Health Podcasts with Dr. Megan Kelly. Continuing education for veterinarian rehabilitation therapists. Learn more at onlinepethealth.com.
Hey vet rehabbers, it's happy birthday Online Pet Health. Well, I cannot believe we are 6 years old already. As they say, the time flies when you're having fun, and I can wholeheartedly say that I love my job, everything about it. So it's been a journey from starting the Small Animal membership in 2017, adding in the Hydro membership in 2018, and the Equine membership in 2019. So we started the Vet Rehab Summit in 2017, and in those days it was also known as Webcon. So for those of you that don't know, this is our annual online veterinary rehabilitation conference. We even had a HydroCon in 2018. And when we added in the equine membership, I decided, no, we can't have 3 online conferences in a year. And that's when we created the Vet Rehab Summit. So we incorporated all the memberships into one online conference. So we were looking at our stats, and we have helped 7,502 vet rehabbers from 57 different countries since we started. I can remember years ago when my goal was to help 1,000. So of course now my goal is to help 10,000 vet rehabbers. So guys, I ask you please to help me to get another 2,500 to get to my goal of 10,000. Please share our content, share the podcast, and let's help as many vet rehabbers as we can all over the world. So a little bit of a story on how Online Pet Health started. So as I said, it started in 2017 and it was just me. So I used to do absolutely everything, even the web development. I did the graphic design, I hosted the webinars. And then eventually I realized midway through 2017, I needed some help. And so Mish joined me. Now, Mish used to work with me at the veterinary practice. So she was the veterinary nurse / receptionist / everything. You know how it is. And Mish, I was a vet working there, and Mish used to do ops with me. And so I had a really good working relationship with Mish, and I knew what her attention to detail and how she was just wanted everything to be organized. So I knew I needed a Mish to help me in my business. So it was awesome when she joined me. And now we are a team of 12 people. And you might think, why do we need so many people? Well, there is a lot that's going on behind the scenes, and we need all these people to be able to provide you the top class continuing education for our vet rehab profession. We have a veterinary and veterinary physio team. They're carefully picking topics and the top lecturers from all over the world. Our website gets updated sometimes daily, but always weekly. With all new free and paid content that we have. And every piece of content is checked to make sure we are putting out the highest standard. And this is how we have become the leaders, I suppose, in the vet rehab CPD business online. So today I want to take the opportunity to thank my team for their support and for having the same passion as I have in helping vet rehabbers. Let me tell you that they love you guys and they would do anything for you. And they really care. And that's why we all work so well together. Also, a big thank you to all the companies that we work with that support continuing education. Thank you to all of you for your ongoing support and just for being the best group of professionals in the world. So before I get all soppy on you now, today's podcast is a revisit of our Webcon. So that's our annual online conference from 2017. This was our very first conference. So I thought we would go back in time and we'd go to the Q&A session about the canine athletes. So the theme for that year was all about canine athletes. It was actually Chris Zink's birthday on the day, and she won Lecturer of the Year. And Chris was she was our keynote speaker. So what an awesome present to win Lecturer of the Year in 2017. So before we head over to that Q&A session, if you are looking for some online learning for vet rehab, you can sign up to our free membership. You can go to onlinepethealth.com/free. We've got some great free content there for you. It's just a little snippet of what's in our paid membership, but it'll just give you a little bit of a taster as to what you can look forward to. All right, so let's go and revisit that Q&A session from Webcon 2017.
Welcome to the Q&A session. What an amazing day of lectures. Thank you, Matt, Carrie, Deirdre, and Chris. You guys have been really, really incredible. It's such an honor to have you all here to share your knowledge and experience with us. And I know how long it takes to put a presentation together. So really a very, very big thank you. and also for getting up so early in the morning. Sorry, Matt, for the 4:30 a.m. wake up this morning. I said to Matt, I thought, no, it'll be okay for Matt because he runs all these marathons. And I know with marathons, you've got to get up at like 3, 4 o'clock in the mornings. And he runs marathons all over the country. So I thought, oh, he'll be the one to get up early.
Better Matt
so
than
before we
me.
start, I know it's just been
Agreed.
mentioned now, but before we start the Q&A, I just wanted to say happy birthday to Chris. I was thinking that maybe she was trying to keep it a secret, but that's what Facebook is for. So Thank you Chris, for agreeing to lecture on your birthday. It's awesome. So let's start with the questions. Chris, one of your questions at your nutrition lecture is, can you suggest a maltodextrin to feed?
Yeah, the one that I like and that I use is called NutriCal. I don't know if that's available worldwide, but I know it's available in North Carolina. It's actually there's a lot of products out there that have maltodextrin in them, but this has got, I think, some molasses, and dogs find it nice and sweet tasting, and so it goes down pretty quickly.
Thanks, Chris. Another question was, can a manganese deficiency be the cause of ligament weakness and predispose dogs to cranial cruciate ligament ruptures?
Yeah, people have theorized that, but I don't know of any actual publications that have confirmed it. Maybe Matt does, but I don't.
It hasn't come up in, I've got the VSMR boards in January, and it hasn't come up on my reading yet, Chris. I haven't seen anything that we've done direct correlations with it.
But I know it's been theorized, and that's another reason to make sure that you change food manufacturers a lot, because that's one of those micronutrients that can vary depending on sourcing of the food.
Thanks. And then there was a question about the raw food feeding. Somebody mentioned that they feed 50% meat with bones, 45% meat, and 5% vegetables to their dog. They add veggie, fruit mash, coconut oil, but they really, flaxseed oil and turmeric. But they really actually wanted to ask you, do you have can you suggest a resource where they can actually get correct and appropriate information about feeding raw food?
Yeah, first of all, let me just say that the diet that she's feeding is going to be, it's very hard to know unless you know what proportion of bones is included in that, because the meat itself is very high in phosphorus. So that's why we need to feed meat with bones, which she's doing to some extent, but you would really want to know what proportion of bones and what proportion of for example, if you were feeding chicken breasts, for example, it'd be very high in phosphorus and low in calcium. But if you were feeding chicken necks, it might be very high in calcium and maybe too high in calcium. So that's a reason to get this kind of thing checked out. Why is my mind going blank on the name of this person? Because she has written 2 books. One is called Canine Kitchen, The Truth Behind the Hype. Monica Siegel. Monica is her first name. Siegel is spelled Segal. And if you go on monicasiegel.com, she has a lot of great stuff, a lot of great books that she's written. She's also written another book called Optimal Nutrition. She also has a number of other booklets that she writes. For example, there's a great booklet that she has that is, if you feed a manufactured dog food, but you want to add more protein to it, like fresh chicken or something, how do you do that while still maintaining the calcium phosphorus balance in the food? And I think the calcium phosphorus balance is the thing that is most worrisome. So I would recommend going to her website, monicasiegel.com.
Thanks, Chris. Matt, this is for you. What is the reason for using polysulfated glycosaminoglycans with caution in dogs with renal or hepatic impairment?
So that's a great question. It actually came up in the product handouts for the brand name, which is Adequan. And there are some thoughts with these that in their path, one of the side effects that we're seeing in some of the studies was that prolonged bleeding times. So if we have animals that already have some organ impairment, it's extremely rare, but we want to be cautious about those dogs that have any other underlying organ dysfunction, especially if we're dealing with liver problems where we might have coagulopathies already. and then using those in conjunction could cause some potential problems. But again, those are extremely rare.
Thanks, Matt. Here's another question. It's for you, Chris. Can you tell us how to prevent lactic or electrolyte imbalances in athletic dogs? And does this manifest as muscle cramps sometimes?
Yeah, I've had that question a lot. So first of all, one of the errors I think that we make with dogs is thinking that when they exercise that they lose electrolytes. And we have to recognize that's not the case. They're going to lose electrolytes if they're vomiting or have diarrhea. But they don't lose electrolytes through sweating like humans do and horses do. And I think sometimes we're a little bit anthropomorphic and we assume that they lose electrolytes through exercise like we do. So that's one thing. And so one thing you don't want to do is you don't want to replenish your dog's water with using electrolytes. They really just need fresh water. If they are working in in a desert environment and working long hours during the day, they can become dehydrated, but that is only through water loss. And so what they need to be replenished with is just water, not anything else. So that's one thing. The other thing is cramping is very difficult to actually diagnose in dogs. I mean, there's a lot of reasons for dogs either becoming stiff or whatever during exercise, and not all of those are a result of cramping, though I think people often think it is. So there are various levels of, dogs with exercise-induced collapse or border collie collapse syndrome and other things that are not really cramping. They really are another issue. So I think the most important thing is to make sure that you don't give electrolytes to dogs for replenishment.
Thanks so much, Chris. Margie asked, I think this is a general question, is the link between joint disease and early sterilization a direct link, or is the fact that sterilized dogs tend to be overweight a factor and often gain weight rapidly post-sterilization? Who's going to answer that?
I can answer that. I can give a partial answer to that. There are now 8 publications that show increased risk of cranial cruciate ligament rupture in dogs that are gonadectomized. And at least 2 of them I know ruled out the possibility that it was related to excess weight in their statistical analysis. So I know it's not only that. The other thing that we know is that if dogs are gonadectomized before puberty, they develop an asymmetrical growth of their bones or asynchronous closure of their growth plates. And so that is going to change the pressures and also the gross physical structure of a variety of the components of a joint. So that is not necessarily going to be related to weight either, but others might have things to add.
I completely agree with you, Chris. I mean, the ones we're seeing now in our rehab and sports medicine service, sure, we have our obese dogs, but I have dogs as young as 6 months of age. I actually had a 4-month-old golden retriever come in recently that has completely blown its cruciate. That one was not gonadectomized early, but I have a couple of cane corsos right now that are going through surgical procedures that are 9 months old and were spayed and neutered at 8 weeks, and they're not obese at all. So there is definitely something with the premature closure of some of these physes potentially and changing the angles with these dogs that's predisposing them to putting them at risk for cruciate ligament disease.
Thanks, Chris and Matt. I've got one for everyone. I work with a couple, it's from Andrea. I work with a couple of neurologists, and we have a couple of current cases that have no or questionable deep pain after hemilaminectomies that are chewing at their feet. They are on gabapentin already. I've seen them right after surgery and started neuro rehab exercises. What can you recommend for these? I'm thinking of starting NMES on these dogs when I recheck them soon. Any thoughts are greatly appreciated.
I'll jump in on that one. My first question is going to be, what dose of gabapentin are you using? We've really started to understand now with dogs that this is probably for that level of problems with neuropathic pain and chewing at the feet. I'm starting these dogs off commonly now at 10 mg per kg TID on gabapentin. So if you're in some of the earlier publications were like 3 to 5 mg per kg once a day, and we're just that's not consistent anymore with how we understand how dogs process it and the levels they need. The other pharmaceutical intervention that I'll add on top of those with gabapentin is actually to add in amantadine at about 5 mg per kg twice a day. Again, a lot of the publications on those are once a day, but we're starting to understand a lot from our anesthesia and analgesia colleagues that we've got some changes to do with those NMDA drugs. And then, adding in NMES, weight shifting, tickling their feet, anything that can kind of induce proprioception and sensation can be helpful. Probably some others have some great thoughts on this as well.
Anyone else want to add to that?
So go ahead, Chris.
It's not Chris.
Oh, Deidre, is that you?
Yeah. It's funny. I had a case of a nerve sheath tumor, and the neurologist actually instead started the dog on Lyrica because he had better responses at that level. And I guess I'm just wondering, because a lot of the neuro cases that the loop works on, one of the things that we might see is these dogs that have been deep pain negative for a while, just like you falling asleep on your arm, and you wake up and you have that pins and needles sensation, and that's, very uncomfortable, but that is the signal of blood flow going back into these areas and neurons forming and synapsing that are probably, the response would be chewing at the feet. So we have definitely used the loop in many of those situations, and found a difference. I would have to look at Natasha's paper when it is published on all of the deep pain negative dogs that came in, if any of those dogs were chewing at their feet, or with the addition of the loop in those cases, did they not, whereas the sham treated dogs did. But PMF has some amazing neurological responses.
This is Carrie. I think my other question to that is, how long has this dog been deep pain negative? So, I think obviously early on, aggressive physical therapy and rehab is extremely important. And by aggressive, I don't necessarily mean, putting the dog in a treadmill and asking for motor function when they're deep pain negative. So for sure, NMES, and my primary target with these guys is quads. We need quads to be able to stand. So starting proximally with the NMES and working distally if you are going to gain any motor function at all.
Thanks so much. Carrie, I've actually got another question for you. Do you have any tips looking at hind limb amputees for improving their core, especially when kyphosis is an issue?
Sure, it is. Where is the kyphosis coming from, I guess, is another question. Looking at these dogs tends to beg more and more questions, and why are they standing in that position to begin with? So is it because the pelvic limb amputation is causing more adduction, as well as just pulling the limb underneath the dog for stability, which is probably the case. And in that case, we can utilize some of the peanuts, some of the exercise balls to off-weight that remaining pelvic limb, but still working on trunk stability, core stability, in really targeting in a low impact capacity.
Thanks so much, Carrie. If one of the lecturers are typing, if you can just, while you're typing, if you wouldn't mind just muting, because we can hear the tick, 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 tick. Carrie, another one. How do you deal with the owner's perception of pain versus fatigue? Despite educating on signs of fatigue and how long they can last, people seem to still direct straight to "my dog is sore." Tired doesn't ever seem to be part of their vocabulary, except if the dog's actually visibly sleeping.
Yeah, that's an excellent question, and I think that's one thing that we need to better understand, as a rehab community, is how do we define fatigue, versus actual muscle soreness, and the biggest way for the muscle soreness is direct palpation. You go in and some of these dogs with the straight shoulders especially, we start to see severe discomfort in teres major. Some of the dogs that are weight shifting forward, they may have a pelvic limb issue. We tend to see discomfort. I mean, to a point where they turn and want to bite. In, you know, as they're shifting forward, and all of those compensations are taken up by the thoracic limbs. So for me, discomfort, pain is more on a direct palpation scale. And then that also kind of brings up the point of, you know, what do we look as reactivity or early back pain, signs of back pain or discomfort on spinal palpation versus epaxial palpation. So all kinds of things to take into consideration that we really have yet to better define.
Thanks, Carrie. I've got another question for you. Do you laser over the SIJ joint in any certain position? The attendee mentioned that Debbie Taraka spoke on a webinar about lasering in a different location, but in a functional position. Sure.
So, you know, I assume we're talking about iliopsoas strain here with SI dysfunction. When to take a step back from that, when I treat iliopsoas, I don't treat the muscle directly. I tend to look at spinal issues, spinal reduced range of motion. I look at pelvic rotation related to SI dysfunction. So I'll manually correct that first, and it may take 2, 3, 4 visits to correct and stay corrected before I even consider starting any type of pelvic stabilization gluteal exercises. Obviously working static into dynamic. After I treat the dog manually is when I tend to laser. So in essence, I'm quote unquote moving a joint, so to speak, with some of the joint mobilization. And because of that, may potentially cause some inflammation in there. So I will laser whatever's most comfortable for that patient. Whether I treat the dog manually, that could also be in standing versus in sideline. So early on, these dogs don't want to cooperate. They're nervous. They're not comfortable in sideline. They don't completely trust me yet. But usually after 2, 3 visits, they're coming in, they lay down, they know it's going to feel better, and they learn to trust you. So I'll treat manually. I will laser in whatever position the dog is most comfortable.
Thanks, Carrie. Here's another question. I think it might be for Matt. Would Galliprant be used as a first port of call for pain relief?
Short answer, no. As much as we understand Galliprant now, as it's such a specific tool in there, it's only approved for management of chronic arthritis. So it's not going to be our first line defense in most pain relief as far as post-surgical pain, or perhaps even for muscle strains and sprains and such like that. So it's a very focused medication. It's got, I think, has great opportunity to use for these dogs with the limited side effects that we've seen and the potential for those going forward. But remember, it's going to take some time to really take an effect, and it's specifically only for arthritis management. It's not going to be for dealing with some of the other conditions that we would use our more traditional NSAIDs for. And I still treat Galliprant as an NSAID, even though it's a piprant. We still obviously want to have pre and about 4 to 6 weeks in CBC and chemistries on these dogs and urines to know that we're not missing any other organ dysfunction or problems, since it's still so new to our field. There's not even a piprant class to my knowledge. Maybe Deirdre, Chris, Carrie, you guys want to chime in? I don't think there's a piprant class approved yet at all for human medicine. So we're on the very edge of the frontier here.
Thanks, Matt. Carrie, another one for you. In terms of measurable outcomes, do you ever use photos of stance or standing as an assessment, especially for owners? Sometimes they forget how their pet looked 12 to 16 weeks back.
For sure. Yeah, I think that's actually a really good tool to use pre and post, especially for not just sporting dogs, but a lot of our conformation dogs and some of these show dogs, because stance is obviously very important. And in the way that these dogs move, in addition to standing, is probably just as important. So not just static pictures, but video before and after. And it's just such an easy thing to do now, with cell phones, and you don't have to get fancy. You don't have to do some of the higher tech. I'm certainly not a high-tech person. So just to be able to show video before and after to these clients makes a huge difference.
Thanks, Carrie. There was a question. I know, Deirdre, you answered it in the chat session, but I think maybe some other people might want to know the answer. Regarding the CC loop bed, what type of PEMF unit or size is embedded in the bed?
Right. So we're in development with our beds right now. We partnered with Buddy Rest and Sleepy Pod, and they're not yet released. The cat one actually has a pretty bigger loop in it, and the dog is a schematic of several loops together. I don't have a 100% foolproof answer because we're still in development, and I got an email late last night, which I did not look at, about the schematics, but last known to me was a modified 20 centimeter loop. When you put all these fields next to each other, you have to modify so it doesn't reverberate off of each other and cause interference, which is part of that. And we also wanted to combat the lack of or the small amount of depth if you were treating, a Rottweiler or something like that, who always laid on one side, but the arthritis was on the other. And one of the other interesting things is there is a very popular PEMF bed out there that many of the clinicians actually use in their clinics, and they have a very low PEMF signal and actually have more magnetic, and they even send magnets with the bed to test it. So that's one of the things where a little bit of education about these things can go a long way. I don't know a lot about magnetic therapy, but PEMF I'm getting to be pretty well versed. And to my knowledge, there is not one PEMF bed out there still in business that actually has a precisely configured PEMF signal.
Thanks for that answer, Deirdre. I don't see any more questions. I'm going to give you guys this the last chance. If anyone wants to ask a question, either in the question area or the chat area.
I'm going to add to Matt's Galliprant. I don't know about a PIPRINT class, but as a boarded internist, I'm on the listserv, and there have been, I think, 3 so far that I've caught reported cases of it increasing renal values. Yeah. So I think that put everybody on pause to not abandon the NSAIDs that they're comfortable with. Everybody has the dose, what they know as, the first side effects, which I think is, medicine is, science and art form. And when you're comfortable with a medication that you've used for several years, yeah, it's great to look at newer technologies. But I was surprised that, there were 3 reported cases, and these were dogs that were put on Galliprant with pre-blood work values, checked afterwards, then Galliprant was removed, values went back down, put on Galliprant again because they actually didn't have another option of another NSAID and increase the renal values. So very important to not be cavalier about this being the next savior.
Mm.
And do you know what the increase in the renal values was, or which ones went up? Do you know the details on that?
I think it was both BUN and creatinine. I was reading in detail the first one, and it was a pretty concise history taking, a very good compliant owner, and a veterinarian who was very, worried about, hey, didn't do well on other NSAIDs and then put on the Galliprant. So again, I'm glad everybody was very studious, but I believe it was both BUN and creatinine. I don't know about proteinuria. I could definitely go back and look.
Do you know how high the creatinine went up to, for example?
I think it wasn't extremely high. It was abnormal for the reference range. And the BUN was like 60 or 70 when it was normal beforehand.
Huh.
Yeah, it really, we do have to always be, I think it really is important for us to be cautious with these new products because so many of them come on the market, and then when we use it in real life, it doesn't always.
Right.
Yep.
Every body processes everything differently.
Yeah.
Great. Okay, I think that brings us to the end of the Q&A.
If you enjoyed this podcast, please hit the subscribe button so you get notified every time I load a new podcast. I'm here every week talking to vet rehab therapists from all over the world about all things vet rehab. Don't forget to bookmark the next Vet Rehab Summit on Saturday, the 4th of November. Come and be a part of the world's largest online veterinary rehabilitation conference created specifically for you, the vet rehabber community. Onlinepethealth members get VIP complimentary access to the Vet Rehab Summit. For more information about continuing education for vet rehabbers, you can go to onlinepethealth.com.